from today we will start about the hematopoietic system, that is the blood. This is a very important chapter from which questions usually came both in the theory, viva and in all types of the questions, long question, short question, MCQ, etc. Today we will start with the hematinics. Mainly we are starting with the treatment of different types of the anemia. So you know anemia. So in all of the world, approximately 1/4 to 1/3 persons are suffering from most commonly the iron deficiency anemia. That is, iron is deficient in them, and that is particularly more if there is pregnancy, if there is adolescence, or in some severe diseases like that. So we have to correct this. Apart from this, there is also some vitamin B12 deficiency. There is also chronic kidney disease where the anemia happens. So all these can be treated by different types of the hematinics. Iron deficiency anemia, what does it mean? It means iron is deficient in our body. So iron is one of the most important element in our body, and for this iron has to be taken from the different foods and iron has to be absorbed. Now what happens in the nature, iron usually happens in two forms, ferric form and ferrous form. You know about the Fe3 plus is the ferric and Fe2 plus is the ferrous form. Now there are some foods or something that contains mainly the ferric iron, some contains mainly the ferrous iron. Ferrous iron is easier to absorb in our body. Ferric iron needs to be converted to the ferrous iron for absorption to our body. So first coming to the hematinics. So these are the agents required for the formation of the blood. So in the physiology you have read about how the blood is formed, different corpuscles are formed. So these are used for the treatment of anemia. What I am saying, anemia is quite common disease in our country and all of the world. Mainly iron, folic acid, vitamin B12, these three are needed. So anemia is basically a condition where there is the balance between the production and destruction of the RBCs are lost. That is, the RBC are produced and RBC are destroyed, and this is the balance is dismantled. That may happen due to blood loss. The blood loss may be acute, for example some road traffic accident, or it may be some chronic, for example some bleeding peptic ulcer or some bleeding hemorrhoids, piles jake boli. So that is the chronic blood loss. Impaired cell formation due to deficiency of essential factors. So if there is deficiency of the iron or vitamin B12 or folic acid, that may lead to anemia. Bone marrow depression, hypoplastic or erythropoietin deficiency can also lead to anemia. Bone marrow depression may happen due to some diseases, due to some medications, due to some cancers, etc. And increased cell destruction, hemolytic anemia. So cell can be destroyed more. That also can happen due to different types of the diseases. So these all can lead to anemia where the balance between the RBC production and destruction of the RBC is disturbed. So now coming to the iron, what I am telling, the iron is one of the most important element in our body. But what happens, the free iron is also toxic to the body. So if the iron concentration will be more in our body, that can lead to some oxidative damage to different types of the cells. So it needs to balanced. The major role of the iron in mammals is to carry oxygen as part of hemoglobin. You know about the structure of the hemoglobin, the iron, which is the main part. Iron deficiency is the most prevalent part of the malnutrition. So if you are asked in the latter, you will see in your practice that malnutrition means both the under as well as overnutrition, and iron deficiency is one of the most common form of the malnutrition. Now how the iron is distributed in our body? Total body iron is approximately 2.5 to 5 gram. It is more in men than in women, and it is distributed like this, like in hemoglobin 66% of iron is present. As ferritin and hemosiderin, these are the storage forms of the iron, present as 25%. Myoglobin present in the muscles 3%. Parenchymal iron, that is iron present within the cells, that is needed for the development of different types of the enzymes, 6%. Hemoglobin, you know about the hemoglobin, this is basically a protoporphyrin, each molecule having 4 iron containing heme residues amounting to approximately 1.1 milligram of iron per ml, and it has 0.33% iron. And this is the daily requirement of iron in our body. In adult male approximately 0.5 to 1 milligram, female slightly more 1 to 2 milligram, infants 60 microgram per kg, children 25 microgram kg, and in pregnancy you can see there is drastic increase of the need for the iron. The need approximately 3 to 5 milligram. Dietary sources, there are some sources where the iron is more and some sources it contains very less iron. Rich iron sources are the liver, egg yolk, oyster, dry beans, dry foods, wheat germ, yeast, somewhat medium, meat, chicken, fish, peanut, banana, apple, but milk and milk products, different root vegetables like potato, that contains very small amount of the iron. So the iron deficient patients are usually also advised to take the nutrition from these items so that there will be more iron available to their body. Now coming to the iron absorption. So what happens, what we are eating average that contains approximately 10 to 20 milligram of the iron, and its absorption occurs all over the intestine, but majority occurs in the upper part of the intestine. Now dietary iron is present either as heme iron or as inorganic iron. Absorption of heme iron is always better and occurs directly without the aid of a carrier protein that is not needed if the food contains heme iron. And the major part of the dietary iron is basically inorganic and in the ferric form, what I am telling, and it needs to be reduced to the ferrous form before absorption. There are two separate iron transporters in the cells. One is the divalent metal transporter 1 DMT1 that is present in the luminal membrane, that is towards the lumen, intestinal lumen side. Another is the ferroportin that is present on the basolateral side. Basolateral means after that there is capillaries so that the iron will be absorbed to the blood and then goes to the different cells. So these two are the important transporter. So what happens, this is the iron absorption, this is important. So dietary iron, what I am telling, it is either present is the ferric form or ferrous form. Heme iron is a separate entity which can be absorbed within the cells without the aid of any carrier. Ferric iron needs to be converted to the ferrous iron, and ferrous iron, ultimately this ferrous iron is entered within the cells by means of a transporter known as the divalent metal transporter 1. And this ferric iron is conversion to the ferrous iron happens due to the gastric juices that is present in the stomach, different types of the reducing agents that is present in the foods also, that leads to the conversion of this ferric form to the ferrous form. Now you can see heme iron also goes inside, ferrous form also goes inside by means of the divalent metal transporter iron. This is the mucosal cells, so intestinal mucosal cells. So on the other side, that is in the basolateral side, there is one transporter, that is the ferroportin or ferroportin 1. Now within this, you can see this ferrous form is again converted, some part of this ferrous form is again converted to the ferric form, and it is engulfed and contained within a substance known as the ferritin, and it is stored within the mucosal cells for some days, and ultimately it is exfoliated and then it goes through the GI system, to the stool it passes, some part, and some part is absorbed by means of the ferroportin to the plasma, by means of the capillaries to the plasma. So basically this is needed again to maintain the balance. If more iron is absorbed, some part of iron is absorbed, some part ultimately resides as a storage form within this mucosal cells, and if it is not needed, ultimately it is exfoliated and goes to the stool, or if it is needed, again it is converted to this form, ferrous form, and again by means of the ferroportin it is absorbed within the blood capillaries. So within the blood capillaries, this ferrous form is again converted to the ferric form, and this ferric form again binds with one transporter protein known as the transferrin, TF. This is the transferrin protein. So transferrin protein binds only the ferric form. So ferrous form is needed for the absorption through the mucosal membranes, either in the luminal or in the basolateral membrane, and after absorption in the blood, it is converted again to the ferric form, and this ferric form binds with transferrin protein, and this transferric ferric form ultimately goes to the different cells and also goes to the bone marrow where the erythrocyte precursors takes it up, and ultimately hemoglobin and mature RBCs are formed. and some part are also goes to the different types of the reticuloendothelial system like liver, spleen, etc., where again it is converted to the ferritin form and stored. Ferritin, hemosiderin, there are different storage forms are there, and again it is stored. Again, when there is deficiency in our body, this ferritin level ultimately drops. So how we can understand that there is iron deficiency? So first there is hemoglobin is less, and another, if we measure this ferritin, ultimately this ferritin will be less if there is inherent iron deficiency present in our body. So it may happen that in the first, due to some acute disease or like this, there is some just temporary decrease of the hemoglobin, temporary decrease of the iron, but the ferritin pool will be normal. So in that cases, just replacing the iron for some time ultimately corrects the iron deficiency anemia. But if there is long standing iron deficiency, the ferritin level also decreased, and again what happens, this transferrin saturation. So how much amount of the iron binds with the transferrin, that is also decreased. So transferrin saturation also changes, so that needs a longer treatment, more amount of the iron needed. That may happen in some other severe disease where intravenous iron can also be needed. So you can see transferrin, it goes to the reticuloendothelial cells like liver, spleen, where it can be stored as the ferritin. In the erythrocyte precursors, it goes inside the hemoglobin as the ferrous form, and ultimately hemoglobin and mature RBCs are formed. So this is how the iron absorption happens in short. Okay. So the same thing, factors affecting iron absorption. So there are some factors that facilitates iron absorption, like acid, like stomach acid, ascorbic acid, vitamin C, amino acid containing SH radical, sulfhydryl radical that is present in different foods also, and meat. So again, in some persons where the iron deficiency is very less or the deficiency is more, the patient can be asked to take vitamin C tablets with the iron, because the vitamin C or ascorbic acid increases the absorption of the iron. This is a commonly used therapy. And there are some impeding agents also, like alkali, like antacids. Hence antacids should not be taken with the iron, the patient is to be told, because it impedes the absorption of the iron. Phosphate phytates, these are mainly present in different types of the vegetables. Okay. Tetracycline is a drug, antibiotic is that are other food in the stomach. So usually the iron tablets are oral tablets are usually the patients are asked to take in the empty stomach. That is, empty stomach increases the absorption of the iron, and if the stomach is full, that decreases the absorption of iron. But there is a problem. What happens? If we are taking iron tablet in the empty stomach, that also increases the chances of adverse reactions. So adverse reactions of the iron are the gastric and esophageal irritation. There may be some nausea, vomiting, metallic taste in the mouth. And you know, if any of your home, some of your father or mother is taking iron tablets, they can say that it is often difficult to continue the iron tablets because the patient becomes non-compliant or non-adherent because of this problem. So there may be flatulence, there may be problems in the gastrointestinal, and these problems ultimately increases when the iron tablet is taken in the empty stomach, but decreases when it is taken in the full stomach. So we have to keep a balance. So ultimately we need to replenish the iron. If the patient cannot take the iron tablet empty stomach because of these adverse effects, in some patients the adverse effect will be more, then we have to give the iron tablets in the full stomach. Otherwise, iron absorption is more in the empty stomach. So mucosal block, the gut has a mechanism to prevent entry of excess iron in the body. So this is the mucosal block. I am just explaining this. So this is known as the same thing. If the excess iron is also absorbed within the body, that also leads to toxicity. So it is either transported to plasma, oxidized to ferric form, complexed with apoferritin to form the ferritin. So apoferritin is a protein to which the ferric form attaches and ferritin is formed, and this ferritin generally remains stored in the mucosal cells and is lost when they are shed. That is, lifespan is 2 to 4 days. So if there is severe need of the iron within these 2 to 4 days, this iron will again goes here and it can be absorbed. But if it is not needed in the body, ultimately it will be shed, exfoliated through the gastrointestinal system. So this is known as the ferritin curtain. So it acts like a curtain so that more iron will not be absorbed, but when the need arises, the curtain will be opened and more iron will come to the circulation. The iron status of the body and the erythropoietic activity govern the balance between these. So iron status of the body, that means what is the content, that is what is the ferritin content of our body, iron status. Erythropoietic activity. So erythropoietic activity can be decreased when there is some cancer, when there is some immunosuppressive drug is taken. So the erythropoiesis, development of the RBC may be compromised. In those cases, ultimately the curtain will be open like this. When body iron is low or erythropoiesis is occurring briskly, ferritin is either not formed or dissociates soon. The released iron is transported to the blood. What I am talking. So this is known as the ferritin curtain. This is known as the ferritin curtain that is present in the intestinal mucosal cells. So iron transport, storage, excretion already I have discussed. So free iron is highly toxic, time and again I am saying. So on entering plasma, it is immediately converted enzymatically to the ferric form and complexed with the glycoprotein transferrin. And iron circulates in plasma bound to transferrin 2 ferric residues per molecule. The total plasma content of iron is 3 milligram and that is recycled 10 times every day. Recycled means by means of the enterohepatic circulation. So turnover of iron is approximately 30 milligram per day every day, 30 milligram per day turnover. So iron is transported inside erythropoietic and other cells through attachment of the transferrin to transferrin receptors, and the complex is engulfed by receptor mediated endocytosis. So ultimately you can see this transferrin ferric iron, ultimately this is the transferrin receptor, this is also the transferrin receptors. Here it is engulfed within, either in the reticuloendothelial cells or in the bone marrow cells. Iron dissociates from the complex at the acidic pH of the intracellular vesicles. So within the cells, within the acidic there is intracellular vesicles. Due to the acidic pH, iron dissociates, and this released iron is utilized for hemoglobin synthesis or other purposes, while this transferrin and transferrin receptors are returned to the cell surface to carry the fresh loads. So ultimately it will be a cycle. They ultimately carries the ferric residues, ultimately attaches with the transferrin receptors, and it is engulfed within the cells. Within the cells there is acidic pH, so that the iron is released, the iron is taken up by the hemoglobin, or it is stored as the ferritin in the reticuloendothelial system, and this transferrin receptor again comes outside of the cells, and the transferrin also comes in the circulation, and again the fresh loads of the iron is taken up like this. In iron deficiency and hemolytic states, when Brick's erythropoiesis is occurring, erythropoietic cells express more transferrin receptors. So when we need more iron to be absorbed, so transferrin receptor expression will be more, selectively more efficient in trapping the iron. Iron is stored in reticuloendothelial cells, what I am talking, like liver, spleen, bone marrow also, different types of the hepatocytes and myocytes. The main form of the storage is the ferritin, and also in some part hemosiderin. So ferritin and hemosiderin are the storage forms of the iron in our body. Ferritin at full saturation can hold approximately 30% iron by weight. Parenchymal iron occurs as prosthetic groups in many cellular enzymes. Parenchymal iron, these are needed for the cellular enzymes like cytochromes, peroxidase, catalase, xanthine oxidase, some mitochondrial enzymes, etc. Now this iron is tenaciously conserved in our body. Daily excretion in adult male, you can see 0.5 to 1 milligram, mainly as exfoliated gastrointestinal mucosal cells. That is very less is excreted out, tenaciously conserved in our body. Some RBC and in bile. What happens in menstruating women, the monthly menstrual loss may be average to 0.5 to 1 milligram per day, that is more. That's why in women the requirement of the iron is more, and it is also the iron deficiency anemia is more seen in case of the women. So the same thing, so it is clear, it is very important for your exams, how the iron absorption, transport, distribution happens. So this picture is very important. If we understand this picture, everything will be clear. Now coming to the preparations on dose. Now iron deficiency, how it is absorbed, how it happens, all is clear to me. Now we have to correct the iron deficiency anemia. Now this correction most commonly is done, what I am saying, either the oral iron preparations or the parenteral iron preparations. Oral are the common ones. Oral means either it can be some tablets or some syrups. Usually the tablets are given. The tablets, you can see the preferred route of the iron administration, and this content, there are different preparations are available, and ferrous form most commonly, or in some cases ferric form with some salts that contains some amount of the active iron. For example, ferrous sulfate contains approximately 100 to 200 milligram. Iron liquid preparation is usually given in children. Tablet is a choice of preparation of adults. Like ferrous sulfate contains approximately 20% iron by weight, ferrous fumarate 33%, ferrous succinate 12%, ferrous gluconate 12%. Carbonyl iron is another formulation, high purity metallic iron in very fine forward form. Most commonly, we are using the ferrous sulfate, ferrous fumarate, ferrous succinate, and ferrous gluconate. These four formulations are available in our country, and that may be used in different persons. What happens in some formulations, the patient may complain of more gastrointestinal problems, so that it can be changed to some other salts. A total of 200 milligram elemental iron is usually needed per day. Okay, infants and children 3 to 5 milligram per kg. And now this total dose can be divided into 2 or 3 times. Okay, 2 times or 3 times. Usually the 3 divided doses. Prophylactic dose is 30 milligram iron daily. So when we are anticipating that the iron deficiency can occur, we can give the prophylactic dose. So what I am talking, gastric irritation, constipation, also diarrhea, are related to the total quantity of the elemental iron administered. So this I have already discussed. Absorption is much better when iron preparations are taken in empty stomach. However, side effects are also more. Some prefer giving larger amounts after meals, while others like to give smaller doses in between meals. So you may be asked that how the iron dosing is usually done, or what are the pros and cons of iron dosing given either in the empty stomach or full stomach. So we have to write about this. Now coming to the parenteral iron therapy, this is also important. So parenteral iron therapy is done injectable route in these cases, in these indications, like when oral iron is not tolerated. Hence, in spite of changing different types of the salts, the patient cannot tolerate the iron in spite of giving it after meals like that. That may happen. Okay, so bowel upset is too much. The patient may complain either too much constipation or too much diarrhea. There may be nausea, vomiting, flatulence, bloating, all can happen. So in those cases, intravenous iron can be given. Failure to absorb iron. So if there is some syndromes where the malabsorption happens, or some inflammatory bowel disease where the absorption capacity of the bowel is already compromised, in those cases we have to give the parenteral iron. Chronic inflammation. So there are some chronic inflammatory diseases like rheumatoid arthritis that decreases the iron absorption and the rate at which the iron can be utilized. Here it can be used. Non-compliance to oral iron, even if the iron is given, even if there is no adverse effect, some patients will not take the medications as it is prescribed. This may happen. So in those cases it is to be given. In presence of severe deficiency with chronic bleeding, so chronic bleeding like chronic hemorrhoids or chronic peptic ulcer, in those cases, along with erythropoietin. So oral iron may not be absorbed at sufficient rate to meet the demands of the induced rapid erythropoiesis. So erythropoietin will come later. It is usually needed when there is anemia in chronic kidney disease. So from the kidney the erythropoietin is released, and this erythropoietin is needed for the erythropoiesis. So when we are using the erythropoietin, there will be bricks hematopoiesis, and ultimately it needs also iron. So we have to give the parenteral iron. So there are different preparations of the parenteral iron. These are the older or conventional preparation like iron dextran, iron sorbitol citric acid. Iron dextran is high molecular weight colloidal solution containing 50 milligram elemental iron per ml. Only preparation that can be injected intramuscular as well as intravenous. But the problems in the anaphylactic reactions, allergic reactions, severe allergy, that is very common with the parenteral iron preparations. Iron sorbitol citric acid, it is a low molecular weight complex, can be injected only intramuscularly from where absorption occurs directly into the circulation and not through the lymphatics. Ferrous sucrose, this is somewhat newer ones. This newer formulation is a high molecular weight complex of iron hydroxide with sucrose. So there is core iron hydroxide and sucrose is attached to it. It is safer than the older iron dextran, safer in form of the anaphylactic reactions. Iron preparations, parenteral iron preparations, always there is problem of the anaphylactic reactions even if in the very newer forms. Dose of 100 milligram can be injected IV taking 5 minutes once daily to weekly till calculated doses are administered. Now oral iron should not be given concurrently until 5 days after last injection, and the incidence of the hypersensitivity reaction is very low. Now, what are the amount, what are the dosing is usually calculated for the parenteral iron? So, iron requirement milligram is equal to 4.4 into body weight in kg and hemoglobin deficit in gram per deciliter. So, for example, if the normal hemoglobin is 12 and the patient's hemoglobin is 6, so we have to 6 into, if the body weight is 70, so 6 into 70 into 4.4. So, ultimately that will be the iron requirement, and that iron requirement is to be replenished by the IV injections of this parenteral or parenteral iron. Now, ferrous sucrose, after the ferrous sucrose there are two newer formulations, ferric carboxymaltose and iron isomaltoside. These two are the most recent ones, usually more are used nowadays, but these are the costly. The anaphylactic reactions are also very less. Ferric carboxymaltose is most commonly used nowadays. Here the ferric hydroxide core is stabilized by carbohydrate cell. So there is a carbohydrate cell to which the ferric hydroxide core is present within the center. It is rapidly taken up by the reticuloendothelial system like bone marrow, liver, spleen. Iron is released and delivered to target cells. So basically this coding and selling is basically done so that the free iron will not be absorbed in any other apart from the target center. So this is basically a form of the targeted therapy where the adverse effect will be less. Administered daily 100 milligram intravenous or up to 1000 milligram diluted with 100 ml of saline and infused IV taking 15 minutes or more. So it can be given either direct injection or it can be infused through the intravenous saline. Both can be done. Incidence of the acute reaction is very low. Pain at injection site and rashes can occur. Headache, nausea, abdominal pain generally is mild. So ferric carboxymaltose, very commonly used. Iron isomaltoside, this is the latest, marketed in India in 2016. Here the iron is bound tightly in a matrix of isomaltoside 1000, which is an oligosaccharide with mean molecular weight of 1000. And after IV injection, again similar thing, rapidly taken up by the reticuloendothelial cells, slowly released for use by the erythropoietic cells. Tight binding with the matrix releases very little labile iron. Labile iron means that is a free iron. Ultimately, this free iron is responsible for the toxicity, and that is quite less with this. Permits administration of the high single dose of the 1 to 2 gram IV over 15 to 30 minutes. Low immunogenic potential, convenient and cost saving due to single short period IV infusion. So what happens even in the ferrous sucrose, we have to give the multiple injections or multiple infusions to correct the anemia. Because if the high volume is given, there is always more chances of the anaphylactic reactions. But with the newer formulations like ferric carboxymaltose and iron isomaltoside, usually we can give just 1 or 2 shots and the anemia, that is the hemoglobin deficit, can be corrected. Mostly these are used in chronic kidney disease patients where the erythropoietin is also given to these patients. So parenteral iron therapy is very important. It is usually comes in the examinations. It can come as short note or individually. So parenteral iron therapy, what are the indications and what are the different preparations? You have to remember. Now uses of the iron deficiency anemia already we know. So most important indications, iron deficiency also accompanies repeated attacks of malaria and chronic inflammatory diseases. So when there is some acute disease for the acute disease or chronic disease for a long time, when the patients are usually tested, usually hemoglobin is done. In most of the cases there may be some iron deficiency anemia, so we have to correct this. Megaloblastic anemia, what happens when breach hematopoiesis is induced by vitamin B12, this is needed in megaloblastic anemia. Iron deficiency may be unmarked. So in most of the cases the iron deficiency anemia and megaloblastic anemia usually coincides. So we have to give the iron in these cases also. And as an astringent, in some of the cases ferric chloride is used in throat pain when some operations or something is needed. So adverse effects already discussed. So oral adverse effect for oral tablets, very common. Nausea, epigastric pain, diarrhea or constipation, both can happen. Staining of tooth, metallic taste. Tolerance to oral iron can be improved by initiating therapy at low dose. Low dose, it is to be started and then we have to build up the dose, escalating to the optimum. Local, if we are giving the injections, there may be pain at site of intramuscular injection, pigmentation of skin, sterile abscess can happen. And with this, with injections, there may be some systemic adverse effect like fever, headache, joint pain, flushing, palpitation, chest pain, dyspnea, lymph node enlargement can happen. So anaphylactic or anaphylactic reactions can happen. There are some cases of the vascular collapse and death also with the older conventional preparations, not with the newer ones. Iron sorbitol causes more immediate reaction than iron dextran. Obviously, this iron sorbitol is the older preparations, so thus should be avoided in patients with kidney disease. So these are the adverse effects of the oral as well as the parenteral iron therapy. Acute iron poisoning. So it occurs when the body is unable to excrete an excess of iron which is deposited in heart, liver, pancreas and other organs, leading to organ failure and death. So it occurs mostly in infants and children when they are taking large amounts of the iron tablets together. That iron tablet is for their father or mother and they have taken, and they have, so ultimately this acute iron poisoning may happen. Manifestation is vomiting, abdominal pain, hematemesis, diarrhea, lethargy, dehydration, acidosis, cardiovascular collapse, all can happen. So treatment to prevent further absorption of iron from gut. So already the iron is taken, so further absorption is to be prevented. So we have to induce vomiting or perform gastric lavage with sodium bicarbonate solution to remain the iron insoluble. So already we have seen the alkali basically impedes the absorption. That's why you have to give the sodium bicarbonate with the gastric lavage. To bind and remove the iron already absorbed. In the last you will read about the chelating agents. That is also very important. One of the chelating agent is the desferrioxamine. So desferrioxamine is an iron chelator that is also very commonly needed in thalassemia patients. In thalassemia patients, we have to give the repeated blood transfusion, and those thalassemia patients are always, there is more chances of the iron toxicity because more and more blood is given, and in those cases we have to use the desferrioxamine or some other congeners like deferriprone. So desferrioxamine is a iron chelator whose indication first is the acute iron poisoning, mostly in the children and adolescents. Next is the thalassemia patients where the repeated blood transfusion is done. And supportive measure is always needed for any poisoning like fluid and electrolyte balance, respiration, BP, diazepam may be given to prevent convulsion, etc., etc. So acute iron poisoning is very common in our country because of this in children. So these are the miscellaneous or adjuvant hematinics. Details is not needed. Just remember the name copper, pyridoxine, riboflavin. It is needed, albeit in very small amounts, but this is needed, and their deficiency may happen in some of the cases. So copper, pyridoxine and riboflavin. Next, coming to the maturation factors. So maturation factors are also hematinics, and these maturation factors are known as vitamin B12 and folic acid. Because this vitamin B12 and folic acid deficiency results in megaloblastic anemia. You have read this in the physiology also. So megaloblastosis. Here characterized by the presence of the large red cell precursors in the bone marrow, and they are large and short-lived progeny in the peripheral blood. So these RBCs ultimately becomes large. They are the precursors. They will not be matured. So maturation of these erythrocyte precursors need vitamin B12 or folic acid. That's why these are known as the maturation factors. So when these maturation factors are deficient in our body, vitamin B12 deficiency or folic acid deficiency, so ultimately maturation of these erythrocyte precursors will not happen, and the precursors are larger in size. So ultimately megaloblastic anemia can happen. So basic defect is in the DNA synthesis. They are therefore called maturation factors, and apart from hematopoietic cells, other rapidly proliferating tissues also suffer. So now coming to the vitamin B12. So there are two forms of the vitamin B12, cyanocobalamin and hydroxycobalamin. So these two forms are complex cobalt containing compounds in diet, and they together are known as the vitamin B12. So vitamin B12 basically a cobalt containing compound, cobalt. Okay. So what are the dietary sources? Liver, kidney, sea fish, egg yolk, meat, cheese. These are the main vitamin B12 containing constituents of the diet. So the different types of the animal sources. Vitamin B12 only source is the animal source. Legumes is only vegetable source, but what happens? By microorganisms harbored in their root nodules. So in the legumes, in the root nodules, there are some microorganisms like bacteria. Ultimately, they synthesize the vitamin B12. So vitamin B12 in our body have to be taken from outside, and the animal source is the most common one. Vitamin B12 is synthesized by the colonic microflora, but this is not available for absorption in us. The commercial source is the Streptomyces griseus. Daily requirement is very small, albeit 1 to 3 microgram. In pregnancy lactation, slightly larger, 3 to 5 microgram, very small. but even if it becomes deficient, ultimately there will be tremendous consequences. So what are the metabolic functions of the vitamin B12? Vitamin B12 and folic acid, these metabolic functions you have read in the biochemistry in details. The same thing, vitamin B12 is intrinsically linked with the folate metabolism in many ways. Megaloblastic anemia occurs due to deficiency of either is indistinguishable. So it cannot be distinguished whether it happens due to vitamin B12 deficiency or folic acid deficiency. The active coenzyme form of the vitamin B12 generated in the body are deoxyadenosine cobalamin and methyl cobalamin. So DAB12 and methyl B12, these are the active coenzyme form. So cyanocobalamin and hydroxycobalamin are the formulations, and the active coenzyme form that is converted in our body is the deoxyadenosine cobalamin DAB12 and the methyl cobalamin methyl B12. In addition, vitamin B12 has some independent functions, like it is essential for the conversion of homocysteine to methionine, essential for cell growth and multiplication, essential for preventing degeneration of the spinal cord. So metabolic functions. So methionine is basically needed as a methyl group donor. So methionine is a very essential element needed in our body that donates the methyl group in many metabolic reactions and for protein synthesis. And this reaction is also critical in making the tetrahydrofolic acid. So from folic acid, dihydrofolic acid and tetrahydrofolic acid, and this tetrahydrofolic acid are very important for different 1-carbon transfer reactions that is essential for our survival. So in vitamin B12 deficiency, this tetrahydrofolic acid basically gets trapped in its methyl form. So methyl tetrahydrofolic acid, ultimately it is a cycle and this cycle will not continue. So a number of 1-carbon transfer reactions suffer. So today you can revise in the biochemistry also, the same thing has been stated and it will be easier to you. So what happens, you can see the methyl tetrahydrofolic acid is converted to tetrahydrofolic acid when the vitamin B12 is converted to methyl B12, and again this methyl B12 is, when it is circulated back to the B12, the homocysteine is converted to methionine. So if there is any problems in any one of this, ultimately all this cycle will be stopped. Purine and pyrimidine synthesis is affected due to defective 1-carbon transfer because of this folate trap. So folate trap means the tetrahydrofolic acid, which is the active moiety, it cannot be converted to the tetrahydrofolic acid from the dihydrofolic acid because it is trapped within the previous forms. The most important of this is inavailability of the thymidylate for DNA production. So DNA will not be produced. So ultimately there will be megaloblastosis, the RBC cells will die. Malonic acid converted to succinic acid by DAB12, another coenzyme form, and it is an important step in propionic acid metabolism. And this propionic acid metabolism is basically a linker between the carbohydrate and lipid metabolism. So ultimately again we can see when there is deficiency, the carbohydrate and lipid metabolism will suffer. This reaction does not require folate and has been considered to be responsible for the demyelination seen in vitamin B12 deficiency due to methyl malonic acid accumulation. So in vitamin B12 deficiency, apart from the problems in the hematopoietic system, there is problem with the nervous systems also, neurological system. Neurological deterioration happens. That will not happen only in folic acid deficiency. This happens due to this chemical reactions. Methionine is converted to S-adenosine methionine by DAB12, may be more important in the neurological damage of the vitamin B12 because it is needed in the synthesis of the phospholipids and myelin. So what is the nutshell of this? The vitamin B12 is needed not only for the different DNA synthesis in the hematopoietic system, but in the neurological systems also, that is independent of its folic acid congeners. So when the vitamin B12 deficiency happens, not only the anemia will happen, megaloblastic anemia will happen, there will also be neurological deterioration, there will be demyelination of the nerves, that will happen. Now how the utilization of the vitamin B12 occurs? Vitamin B12 present in food as protein conjugates. So within the food, vitamin B12 is present, it is present as protein conjugate. It is released by cooking or by proteolysis in stomach, which is facilitated by the gastric acid. Now what happens? The intrinsic factor is released from the stomach, which is a glycoprotein with molecular weight 60,000. It forms a complex with vitamin B12. And this vitamin B12 intrinsic factor complex attaches to specific receptors present on the intestinal mucosal cell and is absorbed by the active carrier mediated transport, just like that of the iron absorption. So you can see for the vitamin B12 absorption, we need the intrinsic factor. So if there is some intrinsic factor deficiency, if there is problem in the stomach, again the vitamin B12 absorption will be hampered like this. It is transported in blood in combination with a specific beta globulin transcobalamin. In iron there is transferrin, here is a transcobalamin 2, most commonly there are two forms. Vitamin B12 is not degraded in the body, it is excreted mainly in bile, 3 to 7 microgram per day, and considerable enterohepatic circulation happens. So time and again it circulates within the body. Now in the absence of the intrinsic factor or when there is malabsorption, vitamin B12 deficiency develops much more rapidly than when it is due to nutritional deficiency. So nutritional deficiency usually occurs for a very long period of times because the vitamin B12 is needed very small amount in our body. But when there is absence of the intrinsic factor, so vitamin B12 even if it is present in large amounts in the food, it will not be absorbed. So ultimately there will be more rapid manifestation of the vitamin B12 deficiency. That may also happen in different types of the malabsorption syndrome also. It takes, you can see, 3 to 5 years of the total absence of the vitamin B12 in diet to deplete the normal body stores. So if everything is normal, the patient is not taking any vitamin B12 containing foods, that takes approximately 3 to 5 years to develop a nutritional deficiency of the vitamin B12. Normally only traces of the vitamin B12 are excreted in urine, but when pharmacological doses like high doses greater than 100 microgram are given orally or parenterally, a large part is excreted in urine because the plasma protein binding sites get saturated and free vitamin B12 is filtered in the glomerulus. Now there are two forms already in the first, we have seen hydroxycobalamin and cyanocobalamin. Of this hydroxycobalamin is more protein bound and better written than the cyanocobalamin. So you can see this is the absorption and distribution pattern where the deficiencies usually happen. How happens the deficiency? So you can see first in the diet, vitamin B12 is not synthesized in our body. Remember, even if it is changed, it is not synthesized on body. Vitamin B12 for us, for Homo sapiens, we have to take from outside. And the only source of the vitamin B12 is the animal sources. That's why in strict vegans or strict vegetarians, usually the vitamin B12 deficiency happens, and usually the vitamin B12 tablets or vitamin B12 treatment is needed. So vitamin B12 deficiency is only happens when the diet is deficient in vitamin B12 for a long period of time. Then you can see intrinsic factor. Intrinsic factor is synthesized from the stomach, and if there is inadequate secretion of the intrinsic factor, for example, pernicious anemia. So you have read about the term pernicious anemia in physiology. So in pernicious anemia, there is autoantibodies so that the intrinsic factor will not be synthesized. So here maybe deficiency happens. Next, it comes and it is absorbed within the ileum part. So if there is some malabsorption syndrome or if there is some ileal disease, so there may be again problems with the vitamin B12 absorption. It attaches with the transcobalamin 1 or 2, most commonly 2. So if there is some congenital absence of the transcobalamin 2, that may happen in some of the patients. So in those cases also deficiency may happen, and then comes to the most commonly vitamin B12 is stored again in the liver. So in the liver iron is also stored, vitamin B12 is also stored, and some part it goes to the different types of the tissues where the different reactions, enzymatic synthesis usually is needed. So rapid depletion of the hepatic stores by interference with reabsorption of the vitamin B12 excreted in bile may happen if there is some liver disease or if there is some hepatic problems. Now it comes, you can see, it comes again the appearance of the abnormal amount. If there is some abnormal transcobalamin 1 or 3, if the abnormal transcobalamin is more, that will not bind with the vitamin B12 and it will not be circulated to the other tissues. That may again happen. And then it comes to the different types of the cells, and if there is normal transport and if there is some folic acid deficiency in these cases, so ultimately that cycle, already we have seen that cycle will not be completed. So there will be folate trapping like that. So these are the areas usually the vitamin B12 deficiency can happen. So what this can happen? Again, clearly first, the most commonly the pernicious anemia or Addisonian pernicious anemia, it is known as. So this is basically an autoimmune disease, that is the antibody is formed against cells. resulting in destruction of the gastric parietal cells. So from these gastric parietal cells, intrinsic factor is released. So absence of the intrinsic factor in stomach and inability to absorb vitamin B12. So pernicious anemia is the most common cause of the vitamin B12 deficiency. Other causes, there may be chronic gastritis, there may be gastric carcinoma, gastrectomy, where the cutting of the stomach is done. For example, in bariatric surgery, malabsorption, where the intestinal mucosa is damaged, like bowel rejection or inflammatory bowel disease. There are different types of the malabsorption syndrome also, like celiac disease, tropical screw, etc. Consumption of vitamin B12 by abnormal flora in intestine, like blind loop syndrome or fish tapeworm infestation. So these are the syndromes where the normal colonic biome has been replaced by the abnormal biome. So ultimately this abnormal flora ultimately consume the vitamin B12 already taken. Nutritional deficiency, already we have seen, it is a less common cause, may occur in strict vegetarians. Increased demand usually happens in the pregnancy and the infancy. So manifestations of the deficiency, how the deficiency is usually manifested. First is megaloblastic anemia. So neutrophils with hypersegmented nuclei and giant platelets. You will read more about this microcytosis, megalocytosis in the pathology. What is pathology? Oh, that are clear. What is microcytic normochromic anemia, macrocytic megaloblastic anemia, macrocytic megaloblastic anemia, like this. So neutrophil with hypersegmented nuclei, giant platelet is present. Glossitis, that because disturbance due to the damage to epithelial structures. So when there is vitamin B12 deficiency, epithelial structures are also damaged. Physical symptoms, this is quite typical and quite detrimental, like subacute combined degeneration of the spinal cord can happen due to vitamin B12 deficiency. Peripheral neuritis, very common. Diminished vibration and position sense, usually patient manifest, strict vegetarians usually manifest with this. So there may be some tingling sensation in the hands or the legs, burning sensation in the foot. So these are different types of peripheral neuritis or neurological symptoms. Paresthesia, the same thing, depressed stretch reflex can happen. Some mental changes for the long-term deficiency, poor memory, mood changes, hallucination, these are the late effects can happen. But the most problematic is the subacute combined degeneration of the spinal cord. So preparations, two preparations are available for the treatment of the vitamin B12 deficiency, cyanocobalamin and hydroxycobalamin. Because of the higher protein binding and better retention in blood, hydroxycobalamin is preferred for the parenteral therapy. Usually hydroxycobalamin is used. Prophylactic 3 to 10 microgram per day orally in those at risk of developing deficiency. And therapeutic is given. Oral vitamin B12 is not dependable, its absorption from the intestine is always unreliable. And injected vitamin B12 is a must when deficiency is due to lack of intrinsic factor like pernicious anemia or other gastric cause. So basically usually injectable treatment is given. Methylcobalamin is a oral form, active coenzyme form of the vitamin B12. It is basically used for correcting the neurological defects in diabetic, alcoholic and other forms of the peripheral neuropathy. So in diabetes mellitus, it is very common, diabetic peripheral neuropathy. There are other drugs, we will discuss about this later. Some antidepressants are used. Apart from this methylcobalamin is also given in addition to this to decrease the burning sensation and tingling sensation. Similarly, in alcoholic, there is also peripheral neuropathy. Other forms of the peripheral neuropathy, we have to give the methylcobalamin tablets. Treatment of the vitamin B12 deficiency, various regimens are used. Usually the regimen used in UK is also used here. Hydroxycobalamin 1 milligram intramuscular subcutaneous daily for 2 weeks or till neurological symptoms abate, because the neurological symptoms is the most fulminant ones and that is also fast to correct. Followed by 1 milligram injected every 2 months for maintenance. In the United States, usually the cyanocobalamin is available and that is used 100 microgram IM or SC daily for 1 week, then weekly for 1 month and then monthly for maintenance indefinitely usually is given. So it is always wise to add 1 to 5 milligram of the oral folic acid or an iron preparation, because reinstitution of the Briggs hematopoiesis may unmark deficiency of this factor, because all these are interlinked. So when we are giving the vitamin B12, there will be rapid erythropoiesis, so we need the iron. So there will be different enzymatic cycles will continue. So if there is some folic acid deficiency, that will become more unmarked. So folic acid has to be supplemented. So now when we are using the vitamin B12, either the hydroxycobalamin or cyanocobalamin, the response is dramatic. So symptomatic improvement usually starts in 2 days. Appetite improves, mucosal lesions heal in 1 to 2 weeks, reticulocyte count increases, hemoglobin and hematocrit start rising after 2 weeks, platelet count normalizes in 10 days and WBC count in 2 to 3 weeks. And neurological parameters improve more slowly, may take several months for complete neurological benefit. Prophylaxis needs to be given when there are some definite predisposing factors for development of deficiency. Mega doses of the vitamin B12 have been tried in some neuropathies, psychiatric disorder, cutaneous sarcoid, sarcoidosis is a connective tissue disorder, and a general tonic to allay fatigue, improve GOT, value, but the value is questionable. So different trials are ongoing for this. Tobacco amblyopia, it is another thing. Hydroxycobalamin is of some benefit. It probably traps cyanide derived from the tobacco to form cyanocobalamin. So with tobacco there may be problems in the eye. This is known as the tobacco amblyopia. Massive doses of the hydroxycobalamin injected IV to treat cyanide poisoning due to smoke inhalation. It is also needed when there is cyanide poisoning. These are the very rare uses of the vitamin B12. Remember, vitamin B12 is mainly used to correct the vitamin B12 deficiency. And vitamin B12 deficiency most commonly occurs in pernicious anemia. Next most commonly occurs in different types of the malabsorption syndromes. Adverse effects are very less, usually quite safe. Allergic reactions occur on injection, probably concomitant. Anaphylactic reactions are very less. So this is about the vitamin B12.